Hello, everyone. Let's talk about Chapter 6 material, which includes an examination of hurricanes as disasters that affect public health. So just a bit of an overview here, talking about hurricanes being large tropical storm systems defined by intense winds, low pressure sensors, and heavy rainfall. In the United States, hurricanes that form over the Atlantic regularly make landfall along the Gulf and East Coast. Um, as you may have seen over the years, typically affecting Florida, Texas, Louisiana, and the Carolinas. Many of you, or some of you, might live in those areas. Coastal exposure, population density, those things help to amplify the risk of these storms to the population that lives there. Hurricanes are categorized based on their potential for damage, not just on wind alone. The Saffir-Simpson hurricane wind scale considers wind speed, central pressure, storm surge, which would be, basically the ocean or body of water surging onto the land, causing severe damage, in most cases flooding. Um, and then we use that Saffir-Simpson hurricane scale to categorize these hurricanes. Many of you have heard of Hurricane Harvey, which we discussed in this chapter. That was back in 2017, was a Category 4 hurricane with winds exceeding 130 miles an hour. And the storm surge reached up to 18 feet. Storms of this magnitude can obviously cause catastrophic damage, destroying infrastructure, overwhelming health systems, and creating long-term public health consequences that extend way beyond their initial landfall. So this image here is showing us the past 150 plus years of hurricanes and where they've hit in the United States. Obviously, as we discussed in the last slide, most of these have affected the southeastern U.S., Texas, Florida, Carolinas, and that's where the we continue to focus our efforts for hurricane preparation. Although a couple years ago now, we did have a designated a storm that was designated as a hurricane hit the west coast, Florida. It was called Hurricane Hillary, and it wasn't very strong, but it was cause for great concern and preparation efforts out here. So, immediately after a hurricane, the public health impacts typically accelerate fast. The widespread property damage, infrastructure failure, and environmental hazards all combine to create conditions for mass injuries, fatalities. They trigger the urgent medical needs, and overwhelming nearby healthcare facilities are often overwhelmed. Um, the hospitals and clinics themselves obviously can sustain a lot of damage or lose power, leaving health systems strained just as the peak demand happens. Now, these impacts are not evenly distributed. Older adults, people with disabilities, those with chronic illness, low-income populations, unemployed individuals, racial ethnic minorities are often hit hardest. Disasters magnify pre-existing social inequities in healthcare access and outcomes, pushing social determinants of health to the forefront. From a public health perspective, Hurricanes and floods are not just natural disasters, they actually become public health emergencies through their social context. Political decisions, different demographic patterns, socioeconomic conditions, they shape, they end up shaping who's exposed, who's protected, and who recovers, and how quickly they recover. Understanding these social dimensions is essential for effective preparedness, response, and recovery. So similar to tornadoes, which we'll talk about later, we have a scale called the Saffir-Simpson scale. It essentially is shown here in this table. We have different criteria that group these categories, the storms, into categories based on wind speed and barometric pressure readings, and then each of those carries with it an estimate of storm surge size and the damage level that can be expected, with category 5 being the worst and causing catastrophic damage due to those high wind speeds and massive storm surges. Hurricane Harvey illustrates how extreme weather becomes a large-scale public health crisis. It happened back in 2017, August of that year. Harvey had made landfall in Texas as a category 4, and it stalled for days, basically sitting over Texas, producing the highest rainfall ever recorded from a U.S. tropical cyclone. Eastern and coastal Texas, especially Houston, experienced catastrophic flooding with more than 60 inches of rain, damaging roughly 200,000 homes and affecting nearly 1/3 of the city. The flooding wasn't just extensive; it was also toxic. As you know, there's a lot of oil industry down there, and floodwater is mixed with petrochemicals, sewage, industrial pollutants, hazardous waste, creating serious environmental health risks. Harvey overall caused about 100 deaths in Texas, with an estimated 125 billion in damage, second only to Hurricane Katrina. From a health systems perspective, nearly 7.5 million Texans were affected. Evacuations, sheltering, toxic exposures, disaster-related injuries caused emergency department visits to spike. Mental health concerns intensified as traditional social support systems were disrupted, especially for the medically vulnerable. The key lesson here would be, the effective disaster response must address both immediate health needs and the pre-existing social vulnerabilities that shape who suffers most. Here's a graphic that shows the distribution of counties in Texas that had made official disaster declarations. You can see most of the southeast part of Texas, pretty much every county there where the hurricane hovered over, caused a lot of massive flooding and so forth. All those counties were extremely affected by the hurricane. And again, Hurricane Harvey highlights why addressing social vulnerability is central to public health emergency response. During Harvey, public health professionals focused on assessing the magnitude of vulnerability across communities, recognizing that different populations enter disasters with very different needs, assets, and capacities. That assessment wasn't just descriptive, it guides where resources should go. It helps make decisions with that information. So it helps prevent avoidable harms, improves health outcomes during emergencies by assessing that vulnerability beforehand. Harvey serves as a powerful case study for public health response, showing how hurricanes rapidly increase demand for emergency medical services, how access to care varies according to social vulnerability, and where gaps in response are emerging. Most importantly, it demonstrates how lessons learned about equity, access, and system strain, medical surge, can be applied to future public health emergencies. Essentially, effective disaster response starts with understanding who is most vulnerable, where they are, and how systems can reach them in time. And here we're talking about medical surge as a major public health issue. So hurricanes, they can cause widespread injuries, illness, and death, and overwhelm the local healthcare systems. Um, the surge happens when the number of people seeking care suddenly exceeds what hospitals and medical infrastructure are designed for. Medical surge is a predictable but often underplanned outcome of disasters. Healthcare systems are rarely built to absorb sharp, widespread spikes in demand, especially during sudden destructive events. Managing this surge requires coordinated public health action. People like myself, epidemiologists, we use syndromic surveillance systems like Essence, which is run by the federal government. It's part of the CDC's National Syndromic Surveillance Project. So we use this data, this data system to access emergency department data to detect spikes in visits. We can estimate how big the surge will be, how many additional patient facilities must be prepared. Environmental and behavioral health professionals identify environmental risks and they anticipate short and long-term mental health needs. Medical surge isn't just a clinical issue, it's a systems-wide public health challenge. It requires data, planning, and interdisciplinary coordination before the disaster strikes, as well as during the actual disaster. The medical surge doesn't stop at the disaster zone itself. Hurricane Harvey made that very clear. Even the Dallas-Fort Worth metropolitan area, which is about 260 miles from Houston, it wasn't directly impacted by the storm, but it experienced a measurable medical surge. For example, before the hurricane emergency departments were operating normally, averaging about 7,500 visits per day in Dallas. And after Harvey made landfall in August of 2017, emergency department visits began to rise. During the storm period, visits increased about 1.6%, but the surge increased 10 days 10 days later. So the average daily visits jumped nearly 6%, reaching 8,000 visits per day. So roughly about 600 more visits per day were being seen in Dallas. Most of those visits were gastrointestinal illnesses, respiratory illnesses, fevers, skin rashes, conditions that are consistent with environmental and infectious exposures from floodwaters. Overall, Dallas-Fort Worth saw a 7.4% increase in emergency visits related to Harvey. Medical surge can be delayed, sustained, and geographically widespread, placing long-term strain on healthcare systems well beyond the disaster's physical footprint. A lot of that surge that we saw, hundreds of miles away was due to evacuations, which played a major role in the numbers increasing that we saw. In the Dallas-Fort Worth area, emergency departments saw that sharp increase. They looked at, in particular, at visits from evacuees fleeing the Harvey impact zone. About 40% of them came from Houston. Before the storm, Dallas-Fort Worth hospitals averaged about 22 evacuee visits per day, and after landfall, that number jumped to almost 80 per day, representing a 260% increase in evacuees seen in Dallas for medical issues. The surge wasn't evenly distributed, with most evacuees coming from Harris, Galveston, Fort Bend, and Jefferson. Evacuees most often sought care for GI issues, respiratory fever injuries, traffic-related injuries, while evacuee visits eventually returned to baseline levels. Their influx significantly strained emergency departments during the disaster period. Evacuation-driven medical surge can overwhelm healthcare systems far away from the actual disaster zone. And here we see that table that was mentioned in the slides previous to this, summarizing the average number of daily ED visits in Dallas before, during, and after Hurricane Harvey. You can see the increase in visits during those different periods. It's a sustained medical surge, testing the limits of the system right there. And that previous table was looking at the overall number of ED visits. This one here is looking at just people identified as evacuees from the storm. Looking at the increase, the average patient visits among evacuees over time as well, before the hurricane, during and after, seeing that 200% jump there. It's pretty significant. All the way 10 days afterwards, they were still seeing a sustained increase in the number of patients seen that were evacuees from the hurricane affected area. So here we're talking about social vulnerability and how that explains a lot of why disasters don't affect everyone the same way. Social vulnerability refers to how populations experience hazards differently based on demographics and socioeconomic conditions. But importantly, it's not an inherent trait of the community. Social vulnerability reflects deeper structural forces like racism, income inequality, and uneven economic development, as well as long-standing social and historical inequities. To measure this, researchers developed place-based vulnerability models. One of the earliest ones was the Social Vulnerability Index. That was introduced back in 2000. It combines physical hazard exposure, like flood zones, hurricane wind risk, with socio-demographic data that we use to map where vulnerabilities are concentrated. So the CDC's Center for Disease Control, they developed a social vulnerability index in 2007 that uses 15 census variables, basically census data that's collected across the country. They use 15 variables grouped into 4 themes. Include socioeconomic status, household composition, minority status, and housing and transportation. That tool, developed by the CDC, allows public health and emergency managers to compare communities, identify those most at risk, and allocate resources more effectively. The key caution, though, is keeping in mind that measuring vulnerability is essential, but reducing it requires addressing structural inequities that created it in the first place. sort of the day-to-day work of public health that we do is trying to address those social vulnerabilities by addressing the underlying structural inequities on a daily basis. And this visual here shows what goes into the CDC's social vulnerability index. You have a variety of measures that combined from the census data allowing people like myself, epidemiologists, we can look at geographic levels, different geographic levels like city level or census tract, to identify which areas have a particularly high level of vulnerability and help try to use that data as part of our risk assessments to work with communities that are disadvantaged and help prepare them in different ways for emergencies. So after disasters, communities with higher social vulnerability are more likely to experience worse health outcomes. And public health professionals are essential to help mitigate those effects. Epidemiologists like myself often work with geographers. I also do this as well using GIS, geographic information systems, to help us visualize where vulnerable populations. Using an index, for example, we can look at which communities where vulnerability is concentrated. These tools help support spatial analysis that identify which factors. You can look at, okay, these areas are vulnerable. What is it exactly? Is it income, housing, transportation? Which of these factors is most relevant? Um, and try to mediate the effects of that on the communities that are involved. So public health policy, disaster management professionals use this information to identify where to put resources. Like, for example, if we know certain communities may be more likely to have, on a day-to-day basis, their vulnerability is high. They may not have access to food, water, medications, shelters. Deploying resources to those communities in advance sometimes can help mitigate the effects of disaster. During a Hurricane Harvey, social vulnerability played a key role in determining where people access emergency medical care. More than 11,000 emergency department visits occurred within the impact zone, while over 2,600 visits occurred at disaster medical assistance team facilities. These provide surge capacity during disasters. Um, GIS mapped GIS mapping revealed clear spatial clustering of care seeking near Houston. So near Houston, we're using GIS maps to identify where people were seeking care. This helped highlight unequal access patterns. Among the 4 CDC social vulnerability themes, socioeconomic status has the strongest influence on how care is accessed. A 10 percentile increase in social vulnerability was associated with a 7% increase in emergency care use within the impact zone, indicating that populations seeking care in the hardest hit areas tended to have lower socioeconomic status. So essentially, socioeconomic status, being disadvantaged in that way, resulted in higher emergency care use. In addition, factors like household composition and disability status significantly influence where people access emergency medical services after Hurricane Harvey. Communities with more children, older adults, and people with disabilities were less likely to seek care within the hurricane impact zone and more likely to use facilities in unaffected areas. A 10 percentile increase in household vulnerability was associated with a 3.5% decrease in care seeking within the hardest hit areas, and this pattern persisted weeks after landfall. Flooding further restricted access to care. Extensive flood conditions limited mobility and constrained where residents could seek emergency services. Together, social vulnerability and physical barriers shaped medical surge patterns, highlighting the need for disaster planning that accounts for both population needs and access constraints. And this table here visually illustrates that strong relationship between socioeconomic status and medical care access, as well as the flooding issues in that row at the bottom. So after Hurricane Harvey, more people sought emergency care in the unimpacted Dallas-Fort Worth area than in the storm's impact zone. Those seeking care in Dallas-Fort Worth tended to have higher vulnerability related to household composition and disability, while those accessing care within the impact zone faced greater socioeconomic vulnerability and more severe flooding. This highlights the importance of using GIS, mapping tools, medical surge capacity data, and social vulnerability frameworks together. These tools help public health practitioners track population movement, anticipate medical surge, target resources, mobilize partners like disaster medical assistance teams, and evaluate access and equity both during disasters and in long-term recovery planning. So that takes us to the end of this lecture. We will talk about tornadoes and their impact on public health in the next lecture. Thank you.